We're probably among, the more users in this nation. Our volume of cardiac MRI is about almost 3,500 this year. Very appropriate, though, you could tell. Questions? Let's see here. Let's start with the first one. Do prior stents, pacemaker allow cardiac MRI? Eric, what do you think?
They're not a contraindication. They're actually considered MRI conditional, and so they are, at our center, we actually have a protocol that allows us to do all cardiac devices, any pacemakers, any defibrillators. Stents are not a contraindication either.
What's the difference between stress PET and stress Spect, briefly?
Boy, I could spend an hour on that.
No, don't.
All right, so they are very different. Spect tracers, single photon tracers are multiple, mostly technetium. PET tracers all have to do with positron emission. And the bottom line is that in terms of the technologies, because of the higher energy, the 511 kV photon of rubidium or any of the PET tracers, they're all the same 511 kV. You get better resolution and you get better counts. So if you look at overall in patients who are obese, you get better results. In patients where you're trying to look at coronary flow reserve in terms of looking at balance ischemia and looking at different territories, you can do absolute flows with PET. And for viability, I mean, PET is hands down over SPECT.
For you, does CTA use less or more contrast compared to coronary angiography? I think this is important. You got it?
So what's the question?
It's right there. Are you seeing those or not?
Oh, does CTA use less or more contrast compared to coronary angiography? Okay, well, it really depends on what you're doing in the cath lab, I guess. We routinely use about 50 to 75 cc's of contrast. If you're in the cath lab and you get multiple shots, you probably can get away with less contrast than we do.
Okay, CTFFR rocks. But we have been getting peer-to-peer on our CTA if we want to do this first before left heart catheterization. Just, I think the technology, I mean, you just tell them very little about what is this. CTFFR.
Yeah. So FFR is a way, it's extremely complicated because it uses fluid dynamics based on using already a nitrate enhanced or nitrate expanded artery and looking at contrast flow down the artery. It actually correlates rather well with what you see in the cath lab, which is really a different way of looking. Even though it's called FFR, it's still different because that looks at pressure changes across lesions as compared to what we're doing with CT. But in reality, they correspond fairly well. And I think what's really coming down in terms of cut points is that if you have a FFR by CT greater than 0.8, it's unlikely to be significant in terms of hemodynamically. If it's less than 0.7, it's probably significant hemodynamically, but there's this 0.7 to 0.8 range, which is still a no man's land, okay? And that was shown in the most recent paper just published in JACC Imaging about a month or so ago. So it's not perfect, but it does help you identify in terms of intermediate lesions whether they have functional significance.
Great. Do you want to answer this? Beta blockers, carvedilol versus metoprolol to prescribe for CAD with heart failure?
Sorry, to your CAD or heart failure? Well, okay, well, I mean, I'll give you my own personal opinion. In people who have low EFs, generally speaking, I use carvedilol, especially if they also have hypertension, because if you look at the data in terms of improvement of ejection fraction, there's a clear-cut dose response with Coreg in terms of improvement of ejection fraction, especially if you get up to high doses like 25 BID. So in my own patients who have heart failure, especially if they have underlying hypertension as well, I tried to push carvedilol rather than metoprolol. If I have someone who just has atrial fibrillation and they have a normal EF, I might then just use metoprolol as a way to control rate.
The good thing is finances is not an issue now that both of them are generic. So Do you give prophylaxis to patients with PPM undergoing procedures to prevent endocarditis? ICD,
For which procedures?
I guess.
Okay, for any procedures? Okay, well, the guidelines, you know, keep changing, okay, in terms of what we should do. If you have an artificial valve, yes. If you have, now the guidelines have changed. If you have significant valvular heart disease, no. If you have congenital heart disease and a shunt, yes. So, but it used to be that if you had any valvular disease at all, you would get prophylactic antibiotics. We are seeing a recrudescence in the number of patients getting endocarditis, and it's always kind of interesting to see if that's maybe due to the changing guidelines. But again, that will bear out in the years to come.
Should calcium score be part of a routine medical screening test considered the highest predictive value? I'm not sure about routine.
Should calcium score be part of a medical screening test? Okay, so, okay. I kind of went through this, but in an asymptomatic individual, I think calcium scoring is your first initial test if someone is at least at intermediate risk for having coronary artery disease, because you identify plaque. You therefore can make a decision in terms of whether you want to treat that individual aggressively or not. And I would say yes, based on the MESA data and everything else that I showed you today. In people, then you get to the symptomatic person. And I also showed you data on that if you have a normal myocardial perfusion scan, it can give you a false sense of security. Because a normal perfusion scan doesn't mean you don't have atherosclerotic disease. It just means you don't have severe flow-limiting atherosclerotic disease. And our own data show that the warranty period of a normal Spect is only about 2 to 3 years. So I think in those populations, and in fact, there's more and more buy-in on this, that if someone has a normal perfusion study and you're concerned about coronary atherosclerosis, that a calcium score is a good thing to do.
Should not be routine. You have to kind of understand what you're trying to figure out the risk of this individual, particularly in an intermediate risk, right? So people who have disease already and have been stented, this is not the place for it. Right?
Exactly. Oh, that's absolutely, that's the other thing. If someone has known disease, don't do a calcium score, please. I've had calcium scores on people with bypass grafts. I mean, it makes no sense, you know.
You found out that there's no calcium in the bypass graft. Newly identified left bundle branch on pre-op assessment, asymptomatic, would stress or echo be indicated?
Okay, well, I mean, left bundle branch is a contentious thing. You know, 20 years ago, we showed that if you do exercise in a patient with left bundle, you have about a 40 to 50% false positive rate. With pharmacologic stress testing, you can still see that with either dobutamine or with or pharmacologic vasodilators are about 10 to 15%. I'll tell you, in my patients nowadays, if they have no prior history of coronary disease, but they have symptoms and they have left bundle, I usually get a CTA.
All right, I'm gonna take the last one. Is lowering cholesterol through diet an alternative to statin therapy? Hopefully it's not and or. You gotta have to have good lifestyle. There's no question. Diet, exercise, everything else. You can't measure exercise as to its beneficial effects, and they are in every classification of everything, including, you know, neurological diseases. You look for statin. This morning we went through all the indications for statin therapy. Yes, you always try diet and exercise first and see, and obviously you need to risk stratify these individuals and see if they have a high calcium score, if they fall in the borderline or a family history.
And I would just add to that, Bill, because I absolutely on target with that. I mean, if you look at the exercise data, and this goes back 20 years, the best predictor of survival is how many METs you do on a treadmill. So it's a very strong predictor, and it's something I think exercise should absolutely be in the equation.
All right, well, why don't we give a hand to these individuals who've been